The products they used to work don't work the same. Makeup doesn't go on the same. They have to change their routine. And like she said, a lot of that is, Dr. said, is a lot of it is related to the estrogen decline.
If we only focus on things like, do you have hot flashes like they did in my day, or do you have problems sleeping, or are your periods heavy, then we're going to miss a whole population of women who are not being given hormones.
Oh, hi, Dr. Axman is here. Welcome. And our moderator, Nicole, is here.
Oh,
Hi, everyone. Well, so today we're going to talk about hormones, HRT, and, how that impairs your health and your skin, of course, because we're derms here. So I'm just going to have Nicole get started.
So welcome everybody. First and foremost, women are hearing so much about hormones right now, from HRT to vaginal estrogen to topical estrogen creams. Tonight, we're separating evidence from hype with two dermatologists who've had a special interest in hormonal skin aging. So we are so excited to have both of you here. And I guess I'll go ahead and kick it off because I know, first of all, both of you are so excited to discuss and provide a lot of information about this very riveting topic. I would ask first and foremost, in our first segment, we'll talk a little bit about why skin changes so much after 40. And that's where many women say they wake up one day and their skin feels completely different. What's actually happening biologically? And this question, I would love to get Dr. Ditteman for you to speak to some of those components of maybe why women are feeling this way.
so we know that as people go into their early 40s even, they can start having perimenopausal symptoms. And they might start as seeing a difference in your skin, whether it looks more inflamed, a new outbreak of acne, perioral dermatitis, things they haven't seen since they were a teenager. But in a way, they're going through teen years again because their hormones are going up and down and changing. So it's really fascinating because we know that once somebody goes through menopause, that we lose 30% of our collagen because the estrogen has gone down, and we see the effect of this on the skin where it's more sensitive, it's thinner, it's looking more transparent, and we're getting wrinkles. So it's a very common process, but it doesn't happen in a day. It happens over time.
Exactly. So I'll make a comment, of course, intrinsic aging, which, menopause is part of it, is one part of aging. I want people to also keep in mind that sun exposure, smoking, exposure to pollution, genetics, metabolic health, all those things are also going to contribute to your aging. But, like Dr. Dintman mentioned, menopause is especially interesting because, all the other things are happening over your lifetime, long period of time. Menopause is sort of like you see all these changes very quickly in a compressed period. People, like Nicole said, all of a sudden they notice that they are looking different, that their skin is not the same. The products they used to work don't work the same. Makeup doesn't go on the same. They have to change their routine. And like she said, a lot of that is, Dr. Gintman said, is a lot of it is related to the estrogen decline. But guys, estrogen decline that leads to collagen loss. But collagen loss starts before menopause. So sun leads to collagen loss. Menopause just kind of like aggravates the process. But at age 25, you're already losing a little bit of collagen. By the time you hit perimenopause, 40s, you already lost 20% of your collagen. And so that's why you're noticing changes. And then once you hit menopause, where the estrogen is very low, then that collagen decline just like accelerates and your collagen really like tanks 30% in 5 years. That is critical and it's going to make big changes in your skin. So no, just kind of like putting the whole process here in perspective.
So that's where I would say, like, Dr. Colombo, I mean, you are so spot on. So what you're saying to us is basically that when we see signs of aging, such as lines, wrinkles, everything, etc., that's really kind of like this has happened way before that moment. Where,
Yes.
goodness, okay.
Yeah. Exactly. So the changes have been happening slowly underneath your skin for a long time. And eventually, I guess you hit this threshold where, changes become noticeable signs on the skin. And so it's important to understand that because you ideally don't want to start addressing your issues once everything's very bad. If you really want to preserve your skin, and I mean, I'm not going to say not age because we're all going to age, but if you want to age, in the best possible way when it comes to your skin, you really want to take care of your skin, really starting in your 20s, 30s, sun protection, good skincare, lifestyle, but eventually those hormones do make a difference. And that's kind of like what we're getting into today.
And that's where that menopause, I guess you would all agree, is really that accelerator, that it's that predisposition meets lifestyle, and then we hit menopause. And there's
Yes. And you were aging the whole time, like you said, but I would say estrogen for women is a huge protector of your aging. It really kind of helps offset a lot of those other things that are happening. But once the estrogen really tanks, you really then take a bigger hit on your, aging process when it comes to your skin, less, like she said, less hydration, more fine lines, collagen goes down. So you see skin is not going to be as firm, elasticity is down. So lots of changes, more sensitivity, like more inflammation. So all those changes become way more noticeable, but the good thing is, as long as we understand the biology, there are a lot of things we can do to potentially intervene earlier.
So, you know that I just returned from the longevity meeting in France in June.
Yeah.
And the most amazing thing about that is dermatology was represented in an unbelievable way because we're lucky to have Dr. Saranya Wiles is running a regenerative medicine lab and clinic in Rochester. And she's doing real science because when we say the word hormones, there are many hormones in the body. We have to think about the thyroid's effect on the skin. We have to think of our insulin resistance, our metabolic health. And we know that if we don't address our metabolic health, our sleep, our stress, that is all reflected in the skin. So it's not just about estrogen. The estrogen is going up and the estrogen's going down. May feel awful when our tank is low with estrogen. We may feel awful when it's spiking, and we see that in our skin. So we're really in a great place right now as dermatologists because we have this whole team of researchers that are kind of almost like validating what we've been seeing all along. We even know that we can tell if someone is going to have increased cardiac risk in their life by looking at their skin. There's new testing done in Europe. So it's really a fascinating time because we all seem to want one thing to do. But as we know with everything in our health, there are many pieces to the puzzle. Dr. Colombo is an excellent example of someone who eats right, works out, does resistance training. I don't know how her stress level is. She looks pretty calm to me. But so she's asked me, like, do I need hormones? And I said, well, I'm not really the person to ask, but I think that what we'll know when we talk to patients, that if we only focus on things like, do you have hot flashes, like they did in my day, or do you have problems sleeping, or are your periods heavy, that we're going to miss a whole population of women who are not being given hormones. Only 1.8% of women in our country are receiving adequate evaluation and care for menopausal care, for metabolic care. So there's a big space there for many of us to approach. And that's why I think she knows that we have Dr. Liz Allen in our practice and growing that way because we're trying to look at what we can do for our skin within. And most importantly first, and then also before we do filler, lasers, all kinds of things, because they won't work as well if you're not also taking care of yourself from within.
100%. The skin is like canvas, is the largest organ, but it really is a representation of your internal health. That's why, I actually was a med derm resident, where I did internal medicine and dermatology. And really interesting, the skin is where the body will manifest a lot of like internal diseases. We would be like the people that would diagnose all these crazy autoimmune diseases because really the symptoms show up on the skin. So you can never forget that connection of your skin to your internal health. And then when we talk longevity, aging, it of course it's a very complex process. And estrogen and the impact on collagen is one element, but everything Dr. Gentleman just talked about is very important. Metabolic health, insulin, resistance or sensitivity, and I think we as derms need to educate our patients on. So I tell you, when people ask me, "Oh, I have all this crepey skin on my body. Like, what treatment can you give me?" Tell them I'm going to lift weights. Um, because, we actually have research showing that, weight bearing exercise decreases inflammation and promotes collagen on those areas that you're kind of working out. So I try to keep a holistic approach always because it really is essential and it's what works. The skin separately from the rest of the body is not going to be healthy. So, it's kind of like overall health that we're talking about. So that's why it's so important that we talk about the hormones and early interventions and when the intervention is proper. So that was going to be our next kind of issue that we wanted to get into, right, Nicole? Like,
I was just going to say, perfect transition. Continue.
yeah. And I know Dr. Gentleman, I'll mention, for her, she took this great course on, hormone replacement therapy, and with one of the pioneers on that. So maybe tell us about that course a little bit, and then let's get into HRT. Yeah.
Yeah, sure. I was so fortunate to be in the first cohort of Dr. Rachel Rubin's course on menopause, all things estrogen, progesterone, testosterone. And since then, we've done it 2 more times because she is a forever learner, a forever researcher, and is just incredibly passionate about teaching everyone about hormones. Because we focus on the things like the hot flashes, but what about frozen shoulder? What about brain fog? What about the anxiety? That we know that many women were put on antidepressants for many, many years when maybe what they needed was hormones. And I think that the other most impressive thing that I've learned from other experts is the concept of inflammaging or inflammaging, the inflammation that we're seeing in the body. And that comes from the processed foods that we eat, that comes from not, having insulin resistance, and a lot of things that are contributing to the inflammation of our skin. So you might find that a patient that hasn't had acne in 20 years is having acne. They may also have it when they go on hormone replacement. So I think that's the most interesting thing I've seen. So many women coming in on hormone replacement, and now they're getting acne. Is it the estrogen, or is it the progesterone, or is it the testosterone? And honestly, the answer is not no.
Fluctuations if they're in perimenopause, No, so and we constantly talk about inflammaging, because inflammation related to mostly lifestyle, let's put it in, that's what kind of drives it mostly, and stress, is a huge contributor to like the decay of our body. So we have to kind of put it all together. But when it comes to hormones, for a long time, we had that major study that came out in the 90s that put the fear, in every doctor when it came to prescribing hormones. It was something that you just didn't do. I went to medical school. I was trained to, God, you never think about giving hormones to anybody because, you're going to give them a heart attack and a stroke and whatever. So it's good that we've come to a time where we were able to look at that data and really objectively like analyze it and see that, there are good things about it. There were flaws in it. And now we're looking at this whole HRT hormone replacement therapy situation in a whole different light. We are individualizing therapy, and we have a much better understanding of like the true long-term risks of that. So Brenda, just
Yeah.
tell us what is the current indication as you learned in the
So
course
yeah.
HRT. So which women should be started on HRT? And then the second question is going to be what age should we consider that?
Gosh, it's such a big question. And so just remember the Women's Health Initiative was like 2003, 4. And it's been since 2018 that we now know that it was inaccurate. So we're almost going on a decade, but we're still so behind in all this. I am not the expert to say when someone starts hormones. But what I do know is that if you ask questions and you listen carefully, you're going to hear one of the more than 30 reasons that people may need hormones. And again, they could be the brain fog, the joints, they could be difficulty with their energy, there could be the more common ones. And so many times you need somebody that has been practicing metabolic health and hormone replacement to get them started on a patch. The great thing is that the studies were done and before we were taking more oral forms of these medications. So they're so much safer as a patch and you can titrate or increase it up as needed and be balancing it with the protective effect of the progesterone, which you need if you still have a uterus. And this is so important because there is not a one size fits all. Although Dr. Rubin wants us to feel like she wants us to embrace it. She also will say that this is a shared risk, that you have this conversation with a patient and you go over their specific needs and the shared risk of why they need to be on hormones. But number one, almost everybody can be on vaginal estrogen and needs it because vaginal estrogen changes the microbiome of the vaginal and the vulvar tissue, and it actually can save lives, decreasing urinary tract infections and decreasing irritation. I think that many of the patients that I've treated in the last 20 years and called them lichen sclerosis, called them various irritations, we take care of vulvar disease. They needed estrogen in addition to the treatment that I do.
I actually have incorporated topical vaginal estrogen for a lot of like my very atrophic lichen sclerosis patients. We now know there was a fear that we would use a lot of systemic absorption was unsafe, but a lot of studies now show us that vaginal estrogen properly applied is safe. There's minimal systemic effects. It's even safe in breast cancer patients. But of course, everything requires proper use.
It's
We have to follow recommendations when it comes to dosing. But going back to HRT, um, uh, I think it's really interesting that, in the past, we would just allow all these women to suffer. But now, it's great that we as a society have options for women. Women don't have to just like disappear and hide under a rock as they get older because they feel bad. They have brain fog, their body's just kind of like falling apart. So we have so many options now. But the indications, I'll say, as per my readings, definitely, for anybody that has hot flashes, night sweats, brain fog, early bone, evidence of any, osteoporosis or bone issues, those are all like sleep disturbances. Those are all great candidates to come and see a physician that does HRT. There are a lot of, doctors that are part of this menopause society and they're on it. They will give you what you need. But again, it's not one size fits all. Let's kind of remind people it's individualized care. And then the patch is so much safer than those pills that were used before. I will mention I am not, in favor of pellets. I know there are a lot of people that have been using estrogen, progesterone pellets. For me, as a physician, my issue with the pellets is the fact that you really don't have control of the dosing. And it makes me very uncomfortable to give people anything where the dose is not, we can't really properly like monitor. And if, there's some adverse, event, you're kind of stuck with the effects of that until the pellet goes away. You can't like undo the pellet. So I think the pellets are something that we need to kind of keep as a side thing. But what she mentioned, the patch progesterone, micronized progesterone combination, I mean, is viable for women that need it. But the question I asked Brenda the other day is, what about, because I asked her, there's a lot of talk on potential preventive benefits of HRT started earlier than menopause, in perimenopause, even on women that don't have, any major symptoms. I think at the Menopause Society meeting last year, there was some observational study done on like millions of women that showed like significant reduction in risks for like, cardiovascular events, neurological events, osteoporosis, and a bunch of like sort of like benefits of women that started, HRT earlier. So what is do you have a thought on that, Brenda? Like, I guess at this point, we just don't have enough data, right? To really.
You asked about age. I think I'll go the other extreme.
Yeah.
I have started 75-year-old women on vaginal estrogen, 80-year-old, and my latest was 86. And she came back after about 3 months, and it's very good situation for her. She is active, and she doesn't have discomfort anymore, and she doesn't have irritation. So the age is not, limited by vaginal estrogen.
So that's systemic, like, the HRT that we're talking about, systemic, like patch progesterone combination.
Well, I think that what I've learned is that, again, it's a very detailed consultation that you have with the patient and looking at their whole metabolic situation. You're not going to just give everybody HRTs. I know you can do that online, but most people are starting very conservatively and focusing a lot on the symptoms. You can get baseline blood work to be helpful as a baseline in showing, how are you feeling when your levels are at certain points, that it's not used all along. From what I've understood, it's not used as the indicator as much as if you go up and down. But many people can be started on testosterone first and vaginal estrogen. And maybe they're working more on energy, on libido. And in addition, there have even been recent studies presuming or implying that maybe it can be protected from breast cancer. So there are going to be a lot of options, but the research is coming and more research is needed.
Exactly.
And we have so many great champions. I can't even name all the list, Rachel Rue and Kelly Casperson, they are just the stars, Heather Hirsch, and the list goes on. But just remember that these are very personal conversations and they should not be done casually because, as we know with the skin, there is no one fix. We know that we need to wear sunscreen. If I had one thing for every person that's, starting today, wear your sunscreen every single day, whether it's light from the car, from the fluorescent lights. And that's going to affect your collagen almost as much as what we know right now about estrogen. We've talked about,
because number one, contributor to collagen breakdown is UV exposure. So if you want less collagen to be destroyed, guys, you got to put that sunscreen on, like every day on a regular basis. So, but I just find this whole HRT kind of topic so interesting because the research, we're in such a different place now, right? Even 10 years ago, we wouldn't even be talking this. Nobody was even people were doing it, but nobody was talking about it. So I think, it will be interesting to see what the real data shows us in the next 10 years. But I know as of now, for all the women watching me, if you do have symptoms, really go see your GYN, and potentially they could put you on medication that can make your life so much more livable. You don't have to suffer with hot flashes, night sweats, sleep disturbances, brain fog where you cannot even remember anything, where you feel like you have like dementia. And so it's important that now we have options for women. As for when to stop HRT, we don't know. But I think as of now, the recommendation is from all the conservative societies is, it's safe to do it for up to 10 years after menopause. But, with more data coming, that may change. And I've seen several patients that they're in their 70s and 80s and are still doing systemic HRT. So I think more data will come and we'll learn more. Okay, but HRT and skin, that's something that I wanted to just kind of bring up very quickly. So studies have been done on that, and there's definitely some benefit of HRT on hydration, collagen, elastin, so elasticity, fine lines. But the results are not like miracles. So it's not like you're going to go on HRT and you're not going to age your skin. So people, have to keep that in mind. And then the other thing I'll mention as a derm, aging is not just the skin, right? You have the fat compartments underneath, you have your ligaments, you have your bone. All those things are also changing over time. So, but of course, healthy collagen, healthy elastin is a good thing, but there are other factors there. But I personally do not prescribe at this point HRT for skin benefits, systemic HRT for skin benefits only. I focus more on, sun protection, always lifestyle, diet, exercise, stress control, good sleep, always that. And then of course, the things that we have available, devices, energy devices, injectables, on skincare. So those things I think now and make more of like an impact than HRT, but it's combination, as we get more data, we'll know. Brenda, do you have any thoughts on topical estrogen for skin?
Sure. And I think in response to what you just said, I think circling back, we're seeing patients that are in GLP-1s and their skin in many ways is looking better again from, I think, decreased inflammation in the body. So don't forget the rest of the hormones, the thyroid,
Of course.
that gets hypoactive, makes your skin dry. So it's not just about the estrogen. That is all part of the puzzle, and you need that holistic approach to it that you can get if you partner with someone who knows about metabolic health. And then we can advise, because if we work on from within, if you decide you want to talk about estrogen on the face, the studies are very in the beginnings of this. We know that it seems to help the barrier function, the dryness, and there's a little bit effect on collagen 1 and 2. But is it as much as using a retinol? I don't think so at this point. I still like to see my patients on a retinoid. If they can use tretinoin, the strongest, or maybe they have to use a retinol. With respect to the estrogen, you can use your vaginal cream on your face. It's a little bit thicker. It's not maybe as pleasant or elegant as other things you do. You're using your vaginal estrogen twice a week after you do your initial once a day for 2 weeks. And so you can use it on your face or your neck. You are probably going to get more absorption than you realize because you're putting, although we know as dermatologists that there's more absorption in the mucosa than there is on the skin, on the face. There was a study that showed that it actually had very little effect if you had a lot of sun damage. So that's another thing. Whereas we know that retinoids repair collagen and make new collagen.
Repair and in the really your keratinocytes repair sun damage, where there's like estrogen based, doesn't seem to do that. But as I
But you can use estriol. I'm sorry, I meant to say so a lot of people are starting to use the weaker strength estrogen, which you can have compounded, and it's a little bit lighter and it can go into your skincare routine. If you're using a peptide in the morning, for example, something like the Elm product is amazing and it's light and wonderful. And then you put your sunscreen on, and maybe you put tinted sunscreen. That's my favorite because it's mineral based. It helps with pigmentation prevention. And then you could use your estriol twice a week. And as more studies come out, hopefully from experts like Dr. Wiles, where she'll be guiding us. So I think we don't know the answers to a lot of these
No,
things
we
yet.
don't. So that's what I was going to mention. We have, estradiol and estriol. They are prescription only, even estriol. Estriol being the weaker element. But, we don't know. What we think, we know with estradiol, actually, there is a little bit of like systemic absorption. Estriol less, but a little bit. But we don't know, like, if you use them for a long time, do you need to protect your uterus with progesterone? Is there gonna be a risk for that? Probably not, but we don't really have the data on that. I will say with both estriol and estradiol, I've had people use it. I mean, it really is not miracle either, but it helps a little bit more with hydration than anything else. A little bit with fine lines. But I will warn people that melasma-prone patients definitely see aggravation of that if they use those products. The other thing I mentioned is people think because it's a cream is safe, so they start putting that all over their body. If you put estriol and estradiol all over your body, then you're pretty much like at that point potentially getting like systemic effects. And so there's, so we need to like, if we're going to go in the direction of using those things, we need to understand it better. But at this point, like you, I mean, I like the concept of what the little benefit that they can do. So I will recommend, in small amounts, in people that are not prone to like a melasma. But of course, I favor the standards that we know work, the gold standard being retinol, tretinoin. I mean, I will mention that some women, 40 plus, with the sensitivity that they develop in their skin, they just cannot tolerate retinol. And I mean, most people can get used to it, but not everybody. So in those cases, alternatives like, a topical estrogen, peptides, and antioxidants, of course, they make a difference.
Dr. Colombo, hold on, because it's so interesting that you're bringing all these points up because you see all of these different companies all over the internet that you can purchase, you can apply. So like your thoughts are surrounding like this could be really a major health hazard, is what you're saying. Not get them the right guidance.
I will say some of those companies, yes, are okay. They are physician led. Alloy being one of them. They do like a lot of like topical estriol based creams for eye. So if you follow their recommendations of the trustworthy ones, it's fine. But I just want people to understand that it's not going to be the miracle cure to like their aging. And that's what she's saying. There's so many processes at play here. And because people now, because of all the hype about, estrogen and blah, 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 people are thinking now that the cure to aging is estrogen. I mean, it's one factor. There are lots of other factors in there. I will say, like I said, I'm not against the idea of them because I'm a believer in doing combinations of different things for like a bigger benefit. They kind of like work synergistically. Um, I personally I tried estriol and I don't even get melasma and he gave me melasma. So I stopped because I didn't see enough benefit to like justify having to laser my face more often. But I do use personally, like a phytoestrogen, which is like a plant-based estrogen promoter, genistein right now. In one of the products, we have the phytoester age eraser. Again, is it miracle benefit? Of course not. And I know most of the benefit that I'm getting is probably because I have access to all those lasers. They're so powerful in reversing things. But I do think, it does help my skin be more hydrated, more glowy, better quality. And it makes me happier to have, healthier skin. So I will mention, there are plant-based estrogen promoters. They're much safer. We know they don't get systemic. Of course, they're going to be much weaker stimulators of the estrogen receptors on the skin, but they still give you a little bit of stimulation. They're not like a solo agent, but they can work well in combination with other agents, and they don't trigger melasma. So I think it's like something worth trying that may benefit you. We'll get more data on this in the future, and we're developing a cream that has another kind of plant-based estrogen promoter that is a little bit more potent than a lot of the ones in the market. So we'll see how, that goes. We're going to run a study soon. I'll let you know what we get results wise from this study. But, I'm open to new things because, but of course I want data to back up, those new things. And so that's where I am. But again, nothing substitute this holistic approach. It's like, I think that's the conclusion. You have to, you know, if you want the best benefit when it comes to like longevity of your skin and your body, it's all connected. You have to, you know, exercise. It's not just the weightlifting, is you also need some cardiovascular, cardio exercise to keep your heart healthy. And
Wasn't it what she said, Dr. Colombo, that longevity is what? Longevity is not a, you mentioned that
It's not a thing. It's not a single product or procedure. It's a team approach.
it's a
approach, and it's a lifestyle. Yeah. And I'm trying to live what I say. Of course, am I perfect and I do everything? No, none of us are going to be like that. I drink wine, and that's kind of killing some of the benefit of the other good things I do. But I try to do it in moderation. So
Well, I think there is a lot of research. We're just not hearing about it. There is a lot of safety research out there already. And like I said, I'm really championing these, people that are running labs, the research studies that Dr. Rubin's doing. And on a small scale, we're learning continuously. Like we're learning about vaginal dryness. And nobody really asks about that. I don't remember ever being asked about that. And we know that sometimes birth control pills cause that. Accutane does. And there's even doctors that have patients on spironolactone that we use a lot for acne that find they get vaginal dryness. Now, in our office, we're doing a survey of all our patients on the medications to see if we can get a just small amount of research or information to share with others, because everything we observe can eventually come from research.
yes.
And studies take 10 years, but we are living our lives now. So we need doctors that are educated, they're reading the latest, they're collaborating with other physicians, they're going to meetings, and they're not waiting for the 10-year study because we're living now.
No, exactly. Like we want, I'm okay actually as a physician in trying new approaches. They're not 100% validated, as long as they're safe, right? Safety is a big one for me. And going back, safety, there's this whole discussion of different kinds of like peptides out there, especially injected ones. But okay, let's get into like maybe peptides a little bit. So people need to understand, because there's people think peptides are these magical things. They don't even know what a peptide is, majority of people, but it's like, small chains of amino acids. Is like it's a little part of like a protein.
Yep.
And they're just molecules that get into your cells and activate genes to produce certain things or not. So you cannot like put all peptides in one category. There's all sorts of different kinds of peptides. And if you're gonna inject things into your body, that can turn on and off genes that can do good things and bad things. I mean, we do need data for that. So I think, there's like an FDA panel recently kind of looking at some of those common peptides in compounding pharmacies. And they just felt like we don't have enough data at this point to say that those things should continue to be done.
Well, actually, the FDA panel was about trying to make them safer by having them be in regulated pharmacies, 503A pharmacies. It was not about saying whether they were safe or not, because right now they're available in gyms, online, and from research labs that makes them dangerous.
Data, like they were looking at, should people have access to those things through, it had to do a lot with compounding pharmacies. And I mean, but the, as I take it, I mean, we don't have the data for that. I mean, we don't have that data. So we don't need that data, because can they be, a lot of those things be beneficial? Probably, but we don't know. But I mean, GLPs are peptides. Those have been heavily studied. So we know that they're safe. But again, even those GLPs are being abused as I see it. I mean, you see normal people taking GLPs and it's almost like they are developing like an eating disorder. So, I mean, we need to, as physicians, prescribe things that are tested and prescribe them appropriately to the right population. I mean, I don't prescribe everything to everybody. It's all
That's a great point, but that's the key thing is that with 503A based facilities and different types of compounding pharmacies, they have to follow very, very strict standards. Like we're on every batch, like it's even a higher level than you can possibly imagine. But to your point, it's like the coin phrase is peptides, peptides, and throwing words around. And a lot of these places are not necessarily a 503A or have the appropriate cert.
oh yeah, because you work with like compounding pharmacies. That's
Different leading go. They follow rigorous. Like I can't even begin to tell you.
Yes, you're so correct. The leading experts in peptides that have been using them 5, 10, 15 years, if you follow them, you'll see the first thing they say is that they're evaluating so many other things in the body first. They're, again, looking at the thyroid, your hemoglobin A1C, your C-reactive protein, your ferritin level. Are you anemic? Are you fighting to be anemic? So it's just a word that's being sort of overused because we know the GLP-1s have so many great advantages. And every day we're finding out new things, even studies showing maybe it'll help colon cancer from recurring, breast cancer, osteoarthritis. That is not my expertise, but all I know is that there are research that there's a lot of learning going on.
But again, I see a ton of patients properly using GLPs where they their doses they're too hot, they lose weight too quick, they lose all their muscle mass, and everything. Yeah, exactly. So they're not getting the full benefit, and some of them don't even need it. So we have to be cautious. We know nothing is good for everybody, and everything needs to be, properly done and to the right population. But I'll talk about peptides and skin. And so, most of them are huge molecules that, to be honest, they don't even penetrate enough to even give you that much of an effect on the skin itself. So they definitely don't get systemic. But, there are, newer peptides. They're smaller molecules. They get into the dermis where the fibroblasts are, and they promote the effect that we're looking for, that collagen elastin stimulation. I'll talk in specific about the GHK copper peptide. Yep. It's an interesting small molecule. This GHK, which is a signaling peptide. When it gets kind of like bound to copper, it's a powerful promoter of wound healing, tissue regeneration, collagen,
Ultimate antioxidant.
elastin, and anti-inflammatory. But one thing for people to keep in mind, GHK with copper, um, you know, is very difficult to formulate with other ingredients. The copper oxidizes everything. It kills your vitamin C, kills a lot of other ingredients. So it has to be done as sort of like a single ingredient, pretty much. So a lot of products out there may have GHK copper with a bunch of stuff that is all kind of like neutralizing each other. GHK alone doesn't have the issue of the copper, so it can be compounded with other, mixed with other things. And it also has been shown to signal the body to produce collagen, elastin, remodel extracellular matrix. Do we know what is the true effect of this stuff? We don't know. We don't have like really big studies. We know that potentially it could be beneficial. Is it better than tretinoin? Probably not. But can it be done as a combination regimen, like you mentioned? That's probably the way. And people that have very sensitive skin that can't tolerate tretinoin, those more powerful, smaller molecule peptides, seem to be like a great kind of like thing to consider. Exosomes, growth factors. So there's like a growing field of like ingredients that we are using. And But again, some of those molecules are too big, or they need we need like better penetration enhancers, better like delivery methods. So I think in the next 10 years, hopefully we'll see a lot of like more exciting, information and ingredients that we can use for our patients. But, I'm always going to be a huge fan of like our lasers.
This has been so interesting, and I think we could do this 3 more times. I know it's there's so much you're learning and I'm learning. We'll share it again sometime. And yeah, please keep us both in mind because we're both incredibly interested in the longevity aspect. And like I said, here at Dermatopia and Viva's Wellness is coming, we have a team approach. So I think that when you ask
people, so Brenda, your office is in Fairfax, right?
Vienna, Virginia,
Yeah, Vienna. Yeah, County, but Vienna. So guys, if anybody needs a great derm in Vienna, Dermatopia, Brenda, and holistic approach, which is really, what you want. You do lasers there, right? Also like in some cosmetic stuff for people that are just curious.
Sure. Like if I had to pick what I'd want a patient to do, I'd want them to wear tinted sunscreen. I want them to use at least one medical active ingredient at home, whether they can tolerate a retinol or one of the new peptide products. And then I want them to do in-office procedures periodically to stimulate collagen, such as microneedling or Lazen D Ultra that I love for pigment with very little downtime. So I kind of like a simplistic approach.
Yeah.
I don't want you buying 5 products. I don't want you to feel like you have to do every laser there is. Because again, I think whatever you do and you do it consistently,
it's constant.
Can make it
and yeah, exactly. There's just people get sometimes fatigued of too much, and cosmetic fatigue is a thing, and we've been talking about 20 steps are really undoable for most people time wise, and honestly, like just don't really produce results because you end up just irritating your skin, and you don't even at that point you don't even know what's creating the irritation. So it's consistency and targeted approach. You need the right, few ingredients. They're going to make a difference, and then combined with the proper procedures. But I would recommend everybody sees like a board certified dermatologist for a lot of those procedures, because I'll say we have way better training and understanding skin, understanding lasers and what they do, and treating complications that even in good hands they happen. And so you want to be in the hands of somebody who's seen the complications and can help you to decrease ultimate potential bad outcomes from complications. So but I think the whole talk that we had is so interesting, and I think it's all about this holistic approach. I mean, I live that approach. I 100% believe in it. And I almost consider myself like a guinea pig to all this, because I really am, like how much benefit can you get from all this, approaches? Yeah. So, but thank you so much, guys.
Thank you.
And Nicole, thank you again, and do it again for sure.
Okay, wonderful. Thank you so much.
Thank you so much.
Bye bye.
Bye.